Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 33. We're in the Virology section. We're talking about negative sense RNA viruses. This is a long module, so get out your seatbelts. We're going to need to take a lot of notes, and this will be something you'll review a lot. We're going to talk about the entire class of these viruses, and they encompass a lot of human disease. We'll talk about rabies, we'll talk about swine flu, we'll talk about respiratory syncytial virus, measles, and mumps. We'll try to go slow and make sure you have time to get everything down. These are frequently tested on both from an epidemiologic and clinical presentation to also their different DNA and also their genomic strategies for replication. Hold on and we're going to get started. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 33, Negative Sense RNA Viruses. RNA viruses are all single-stranded except the reovirus family, which is rotavirus, which has double-stranded RNA. All RNA viruses except the positive sense RNA have to carry their own polymerase. All negative RNA viruses are enveloped, so these are a couple rules to help you remember which is which. This table is really important for you to get down to memory. What it does is it highlights the different negative sense RNA viruses and organizes them based on envelope, their shape, where they multiply, and the major viruses they cause. Negative sense RNA viruses include paramyxo, rhabdo, phyllo, orthomyxo, bunya, and arenavirus. And we'll talk about each one. This figure shows the negative sense RNA virus's replication cycle. We have on the top fusion of the virus with the host envelope, and then we get the lysosome, and we release the single-stranded negative RNA. Single-stranded negative RNA becomes double-stranded negative RNA, which then yields positive sense positive RNA. From the mRNA, you can get replication, you can get protein translation, and early proteins, and then late proteins. After you have replication, you have your genome, you have your proteins, you got your nucleocapsids, and then you can go out to the host cell membrane. You can fuse with that and then release. Orthomyxoviruses are pleomorphic. As shown in the figure, they have numerous different shapes. They are the causative agent of influenza types A, B, and C. There are many strains separated by antigenic differences in the hemagglutinin and neuraminidase molecules. Type A infects humans, birds, and other mammals, which they can zoonose with. Type B and C are isolated from humans only. They cause a febrile respiratory illness with systemic symptoms such as fever, headaches, and myalgia. This is the flu. This is true influenza caused by influenza A or influenza B, or C, which is much milder. Again, febrile respiratory disease with systemic symptoms caused by a variety of other organisms is often called flu as well. Orthomyxoviruses are helical nucleocapsid viruses. They're single-stranded negative sense RNA. They're linear and they're segmented with 8 segments. They have to carry their own RNA-dependent RNA polymerase, and this transcribes the negative polarity genome into messenger RNA. That messenger RNA can replicate in the nucleus and in the cytoplasm, and replication in the nucleus permits the virus to cannibalize capped 5' termini of cellular RNA and use them as primers for viral mRNA transcription. It just kind of hijacks the host protein synthesis machine and uses it for its own use. Orthomyxoviruses have a number of cell surface markers shown here in this figure. Hemagglutinin and neuraminidase are important cell surface markers, and we use them as targets in antiviral therapy. You do have the heliconucleocapsid, which is RNA plus a nucleoprotein. You have a lipid bilayer membrane. You have a polymerase complex, and you have an M1 protein. You can differentiate the subtypes of influenza by the hemagglutinin or neuraminidase protein, so you'll often find an H and an N designation. You can also look at the nucleocapsid or matrix protein or phosphoproteins, which are involved in RNA transcription and replication. This is another figure showing the computerized 3D image of influenza. It has its genome coiled around proteins on the inside of the envelope coat. On the outside you have hemagglutinin and neuraminidase. A third picture highlights the hemagglutinin and neuraminidase. These are popular features. They're important to know about influenza. The hemagglutinin protein, it helps with attachment and fusion. It's attachment and membrane fusion in the endosome of the infected cell. It attaches to sialic acid-containing glycoprotein, or the glycolipid receptor on sites of host cells. the sialic acid receptors on red blood cells or respiratory epithelium. Hemagglutination and dumping of viral genome into the host cell is what happens when it binds. You have antibodies which block against hemagglutinin, and they block binding and prevent infection. That's what we give vaccines for. It's against the hemagglutinin and neuraminidase. Neuraminidase acts on hemagglutinin receptors by splitting off the terminal neuraminic sialic acid. This results in destruction of the receptor activity. Neuraminidase also cleaves neuraminic acid and disrupts the mucin barrier, exposing sialic acid binding sites beneath. This allows hemagglutinin to fuse and attach efficiently. So it plays an important role in viral release from infected cells. Antigenic drift is where the hemagglutinin and neuraminidase accumulate mutations. So they have small, subtle changes in each of the proteins, and that allows the immune response to no longer be fully protective. It's what causes sporadic outbreaks and limited epidemics. That's in contrast to antigenic shift, where we get entirely new hemagglutinin or neuraminidase proteins. We do not have any pre-existing antibodies, and we can get pandemics or worldwide increase in the number of infections. Influenza A, but not B, can trade RNA segments between animals and humans. You get reassortment when two different influenza viruses co-infect the same cell, so you get the mixing of RNA segments into hybrid viruses. This is a new hemagglutinin or neuraminidase glycoprotein that's never been exposed to the human immune system and can cause a lot of problems. The swine influenza or H1N1 flu is any strain of the influenza family of viruses that's endemic in pigs. It's also known as SIV, and the strains include H1N1, H1N2, H3N1, H3N2, and H2N3. The USMLE Step 1 will not test the strains of SIV, but it's important to know that that's how they're designated, by the H and the N number. Swine flu influenza is common in pig populations worldwide, and you can get transmission from pigs to man. It's not common, but it does happen, but it does not always lead to influenza, but it can often lead to the production of antibodies. The changes in the genetic patterns of the viruses usually occur in pigs or birds, which is why we have avian flu or swine flu. Symptoms of zoonotic swine flu in humans are similar to those of seasonal influenza, such as fever, chills, sore throat, muscle pains, headache, coughing, weakness, and general discomfort. The virus isolates in the U.S. swine and turkey stocks, where triple reassortments containing genes from human, swine, and avian lineages can mix. The human seasonal influenza vaccine is given yearly, containing H1N1, H3N2, and B, may afford some protection against swine flu, but most vaccine manufacturers feel it will be little and it's not guaranteed. So for the seasonal vaccination, they take the most common types of those that we've already seen and put those together to generate immunity in people who get it. The problem with swine and avian flu is that we've never seen these mixtures before, and so it's hard for us to be able to be prepared for it. So where do the new hemagglutinin neuraminidase come from? There are 13 types of hemagglutinin and 9 types of neuraminidase, and they all circulate within the birds. And the pigs can have avian and human influenza, and so they're great mixing grounds for the viruses. So this is just an example, again, of the orthomyxovirus, or the influenza virus. You've got the hemagglutinin and neuraminidase, and you can have avian or human or swine genes because you've got a segmented genome in 8 different parts. One could come from each different animal, and so you can see there's a vast opportunity for recombination. So question. Which of the following statements regarding antigenic shifts is associated with influenza, which is incorrect? So A. Antigenic shift occurs as a result of genetic reassortment between viruses of different species. That's true. That's the definition of antigenic shift. B. Antigenic shift is associated with major changes in hemagglutinin or neuraminidase or both. True. C. Antigenic shift is due to point mutations in the RNA genome. Answer C is incorrect. Antigenic drift is due to point mutations in the RNA genome. Those are minor changes in these proteins which we may not have seen before, but are very similar to the ones we already have antibodies against. And then D, antigenic shifts are responsible for influenza epidemics and worldwide pandemics. Absolutely true. This table lists influenza pandemics in the past. It's not every single one of them. In fact, it only goes back to 1947. But you can see that the prototype strain changes in different countries, and you can see the subtypes change. Where we get a new H or a new N that we haven't seen before, it's an opportunity for us to really get sick. Transmission of influenza is aerosol spread. You need 100 or you get 100,000 or 1 million virions per droplet. It says 18 to 72 hour incubation, and then you get shedding before you even know about it. The pathogenesis includes inhalation of viral particles. The neuraminidase degrades the protective mucus layers. The virus gains access to epithelial cells. It interferes with the functions of these cells and then kills them, releasing new viral particles. Recovery is dependent on interferons. They limit viral replication, but they also give us the side effects of fever, myalgia, fatigue, and malaise. Cell-mediated immunity response via MHC class I cytotoxic T cells help us lyse the virus-infected cells. Tissue repair often takes some time. Humoral immunity in the form of IgG and IgA is less efficient, but it does last longer. You get antibodies to both hemagglutinin and neuraminidase, which are protective. The hemagglutinin antibodies can neutralize, and the antibody to neuraminidase limits viral spread. Again, symptoms of influenza include myalgias, fevers, headaches, cough, rhinitis, and some ocular symptoms. Clinical findings include an incubation period of 1 to 2 days, myalgias, headaches, and cough that will last about a week. You get worse disease in the very young, or the very old, or the immunocompromised. They can get a post-influenza pneumonia with Staph aureus. Then those who have heart or lung disease are also worse. Pulmonary complications include tracheobronchitis in young children, primary influenza virus pneumonia. You can get secondary bacterial infections of Staph aureus, H. flu, or strep pneumococcus. Non-pulmonary complications include myositis. It's usually rare. It's greater in children and greater with type B. You can also get cardiac complications. If you treat children with aspirin, you can get Reye's syndrome, which is a liver and CNS disorder. And you can get Guillain-Barré syndrome, or peripheral nervous system disorder, where you have antibodies against the myelin proteins, and you get demyelination and polyneuropathy. Mortality with influenza often comes from bacterial pneumonia or cardiac failure. This is where people die from influenza. Fortunately or unfortunately, 90% of the deaths are those who are over 65 years of age. Lab diagnosis is dependent on direct immunofluorescence, or the EIA. You can do a neuraminidase assay. You can do isolation, which allows you for genetic or antigen analysis from a nose or throat swab, and you have to tissue culture on eggs. Serology is helpful. Most likely, with the epidemics, you're going to use real-time PCR. The shell vial is good, but takes about 24 hours. You get a provisional diagnosis, you get the clinical picture, plus the outbreak. Therapy and prevention for influenza includes rest, liquids, Tylenol. You can try amantadine and rimantadine. They prevent the uncoating of influenza A. They block the ion channel of viral M2 protein. It's good for high-risk patients until we can get a vaccine-induced immunity. And it must be given within 2 to 3 days. There are new neuraminidase inhibitors such as zanamivir and oseltamivir. These prevent the release of virus, but also must be given within 2 or 3 days. And then we have vaccination to prevent. We have inactivated or attenuated live vaccines. Reye's syndrome is a disorder in children after they get aspirin. They get fatty deposits in the liver. Their CNS system is involved with brain edema. They get vomiting, lethargy, encephalopathy, and can develop a coma. The risk factors, again, are youth, certain infections such as influenza, and aspirin administration. So we don't give aspirin to children. The influenza vaccine is often a best guess of the main antigenic types which will be seen in the next season. It consists of killed influenza A and B virus, usually 2 recent strains of the A virus and 1 of the B virus. Each year they choose which variant of subtype is the best to use for optimal protection. It's an inactivated vaccine. They grow it in eggs, so people who have allergies to egg products can't have the vaccine. And they have a subunit vaccine for children. With the H5N1 avian flu seen in Asia recently, there is a race to develop a vaccine for this. Also, a live attenuated aerosol vaccine is available for 5 to 49-year-olds. Guillain-Barré syndrome was seen specifically in the 1976-1977 swine flu vaccine. They gave 35 million doses of influenza vaccine in order to stave off a pandemic. Of those 35 million vaccinations, 354 cases of Guillain-Barré syndrome were found, and there were 28 Guillain-Barré syndrome-associated deaths. Recent vaccines have been improved, so there's much less chance of Guillain-Barré syndrome. There is a bacteria that can also cause Guillain-Barré syndrome, if you'll remember from our bacterial modules, and that's Campylobacter. Let's do a question or two. A 16-year-old male presented to his doctor with a 4-day history of fever, headache, non-productive cough, loss of appetite, and severe myalgias. Lab data revealed normal electrolytes and CBC. Monospot test was negative. Chest X revealed a right lower lobe infiltrate. The sputum gram stain was unremarkable. What's the most likely pathogen? This is a difficult situation because it's a kind of a non-specific systemic disorder, and so we can look at each of the answers and see which ones would help. Epstein-Barr virus is usually going to have a monospot test, although not always, but would be unlikely to be associated with a right lower lobe infiltrate. Influenza virus hits head-on with everything: fever, headache, non-productive cough, and the myalgia. It's going to have sometimes an infiltrate, but not have any monospot activity. Rhinovirus is most likely going to cause a cold, and so you're going to have a runny nose, maybe a sore throat, but not usually the myalgias or an infiltrate. Measles virus is going to be associated with a rash and shouldn't have any changes on the chest x-ray. Next question. Which of the following statements regarding the influenza virus is false? A. It's an RNA virus. B. Its genome is unsegmented. C. Hemagglutinin and neuraminidase are virulence factors. And D. It's a member of the orthomyxovirus family. We know that it is an RNA virus. We know that it's segmented, which allows it to have antigenic shift. We know hemagglutinin and neuraminidase are important, and we know that it's a member of the orthomyxovirus family, so B is the answer. Next question. Which of the following is not a characteristic of the major virulence factors of influenza virus? A. Neuraminidase degrades mucin in the respiratory tract. That's true. B. Hemagglutinin binds to the epithelial cells in the respiratory tract. That's also true. C. Neuraminidase plays an important role in the release of virus from an infected cell. That's true. D. Antibodies to neuraminidase are neutralizing. Now, they don't neutralize, but they do prevent release of the virus from the infected cell. Next up, we have paramyxovirus, which includes measles virus, mumps virus, RSV, and parainfluenza virus. These are enveloped, non-segmented viruses that are single-stranded negative sense RNA viruses. They have helical symmetry, and they cause syncytia. Question. The first event following paramyxovirus infection of a cell is A. Translation of the incoming RNA genome. Well, that's hard because it's a minus sense RNA, and so that's not going to be right. B. Degradation of minus sense RNA. That really wouldn't make sense if it's trying to propagate itself and make more viruses. C. Reverse transcription of minus sense RNA. Well, they don't actually do reverse transcription into DNA. And D. Synthesis of plus sense RNA by the RNA-dependent RNA polymerase. That makes sense. You're a virus, you've got negative sense RNA, you want to make positive stranded RNA, and so you have a virus with you, you have a protein with you that's RNA dependent, and it makes positive sense RNA, so you can start making your proteins. D is the answer. Measles virus is also called robeola, and it's from the genus Morbillivirus. There are strains H and F, but no N. Transmission is through aerosol route. It's very contagious, and it has a 2-week incubation period, so you can be contagious for 2 weeks before you know it. Once you inhale the virus, it replicates in your respiratory tract, moves to the lymphoid tissue. Then you get widespread viremia, and it grows in your epithelial tissue, so you get this morbilliform rash. Look at that rash. Measles has a well-defined prodrome. It's characterized by conjunctivitis, swelling of the eyelids, photophobia, a high fever, a hacking cough, rhinitis, and malaise. If you look on the tongue, you'll see Koplik spots, which are small, red-based lesions with a blue-white centers in the mouth. It's an early sign. And you get a non-pruritic maculopapular rash that begins on the face, spreads to the trunk and extremities, and includes the palms and the soles. I think this might be the third rash we've talked about that includes the palms and the soles, including secondary syphilis and Rocky Mountain spotted fever. You can get a posterior cervical adenopathy. That's common. Clinical findings for measles include uncomplicated disease, fever, with the 3 C's of coryza, cough, and conjunctivitis. You can also get Koplik spots, which are white on a red throat, and a maculopapular rash. If you get complicated disease, you can get giant cell pneumonia, secondary bacterial infections like otitis or pneumonia, encephalitis about 2 weeks after the rash. A late effect is subacute sclerosing panencephalitis, which is 1 in 1,000 autoimmune attack against the myelin-basic protein in the CNS. A brief note about SSPE, or subacute sclerosing panencephalitis, is that it's due to defective measles mutant virus. The typical history is of measles at age 2 or younger. It persists in the CNS for at least 6 years, and then presents with behavioral changes, intellectual deterioration, laziness, clumsiness, and periodic involuntary jerky movements. It's associated with optic atrophy and oligoclonal banding in the CSF. SSPE can occur following vaccination with live measles virus. Typically, there's a 6-year interval between measles infection and symptom development. It involves both the gray and the white matter. Measles diagnosis is based on serology usually, with IgM found in the bloodstream. You collect samples 3 days after the rash. You can do a nasopharyngeal swab and do a fluorescent labeled antibody, but the diagnosis is usually made on clinical grounds. Treatment for measles virus is supportive. You can treat the complications appropriately if they get encephalitis or pneumonia. We have vaccination to prevent measles, and we have an attenuated live vaccine, and we can give immunoglobulin if we need to. This next slide shows a list of the viral exanthems, which were the most common childhood viral rashes you'll see. They were initially listed by number, and here they are. With first disease by rubeola, second disease varicella, third disease from rubella, fourth disease is scarlet fever, fifth disease is erythema infectiosum, and sixth disease is roseola. I guess the only one on there that's not viral is the fourth disease, scarlet fever. Question. A 4-year-old boy presents with coryza, conjunctivitis, photophobia, and Koplik spots. The most likely pathogen belongs to which of the following groups? So we have measles here. Basically, with the 3 C's, you've got a rash, you've got Koplik spots, and so we know that measles is a paramyxovirus, and so we have to go with D. Next question. A 7-year-old boy presents with conjunctivitis, lacrimation, nasal discharge, and small red lesions on a blue-white center on his buccal mucosa. This is followed by a maculopapular skin rash. The most likely pathogen is measles. That's the classic definition. If you remember that, you'll be in good shape. Measles can be diagnosed with which of the following lab tests? Viral antigen in urine? Not really. We do think about that with Legionella, though. Hemagglutinin inhibition test? Yes, that's what you use for a measles diagnosis. Antibodies to neuraminidase you're going to find with influenza. And detection of the viral antigen in spinal fluid can be for a number of viral encephalitides. Question. A 9-year-old girl develops behavioral changes and her performance in school and physical activity, sports, begins to deteriorate. 7 months later, she has a seizure disorder and focal neurologic symptoms. She ultimately develops paralysis and dies within the next 6 months. The patient may have had which of the following viral diseases at an earlier age in life? So this is a really unique syndrome. There aren't any other viruses that we talk about that can kill you 6 months later or 6 years later. So you think about subacute sclerosing panencephalitis, which you get as a late post-measles sequela. Mumps is the next virus we're going to talk about. It's a common cause of parotitis, pancreatitis, orchitis in adult males, meningoencephalitis, and polyarthritis. It's transmitted by aerosols from respiratory secretions and saliva. You can secrete it in the urine, and it's very, very contagious. The mumps life cycle goes through inhalation, and then it replicates in our respiratory tract, moves to our lymphoid tissue, sets up viremia, goes throughout the whole body, and spreads to the salivary glands. There's a 1 to 2 week incubation with this one as well. Clinical findings include a 2 to 3 week prodrome of fever, anorexia, malaise, and myalgia, and you have inflamed, tender parotid glands. You base this, often your diagnosis is clinical, but if you want to, you can use serology. You can do an ELISA for viral components. You could do a complement fixing antibody to the soluble antigen for recent infection diagnosis, and you can check amylase to see if it's elevated. Treatment is supportive. Prevention is from the attenuated vaccine, which we give with the measles, mumps, and rubella. There's only one antigenic type of virus, and so we've been good at getting rid of this. Question. An 18-year-old freshman presents with a headache, nausea, vomiting, fever, nuchal rigidity, spinal taps consistent with viral meningitis. Physical exam also reveals testicular pain, mild swelling and tenderness. He recently had an upper respiratory infection with a parotid gland swelling and tenderness. The most likely pathogen? This question is a good example of everything that mumps can do to you. It can cause encephalitis, it can cause orchitis, and it certainly causes parotitis. When you get all three of them, that's the only thing that you can have, is mumps. It's not measles without a rash. It's not herpes simplex without the vesicles. Coxsackie V usually causes a rash and can affect the mouth and the hand and the foot. But this is mumps. Next question. A 12-year-old male presents with painful swelling of the testis, enlargement of the parotid gland with fever, anorexia, and jaw pain during eating. These symptoms resolve spontaneously in 2 weeks. The most likely diagnosis? This is a softball. You can hit this out of the park with these symptoms. It's mumps. Which of the following statements regarding the mumps virus is false? A. It's an enveloped virus. That's true. B. Its envelope contains neuraminidase that degrades the protective mucus layer of the respiratory tract. That's true. C. The envelope contains hemagglutinin and fusion protein. That's true. Both ortho and paramyxoviruses have hemagglutinin, neuraminidase, and fusion proteins, so that's going to be there for mumps virus as well. D. Phosphorylase is an important virulence factor. That's false. Respiratory syncytial virus is highly contagious, with peak epidemics in the winter and early spring. It does not have H and N proteins like the other paramyxoviruses do. It virtually affects all children before the age of 2, and there's 90,000 hospitalizations annually because of it. Mortality, fortunately, is less than 1%. It causes a bronchiolitis. In infants, it can also cause pneumonia. It's a cause of a common cold, and you can cause croup, rarely. Unfortunately, there's no lasting immunity, and so these children are prone to reinfection. Respiratory syncytial virus is spherical or pleomorphic. It's enveloped, single-stranded, negative-sense linear RNA. It does have an F protein and a G protein, but it doesn't have the H or N proteins like the other members of paramyxovirus. The F protein, or fusion, fuses the viral particle to the host cell. It fuses the neighboring cells to create a syncytium. The G protein is highly glycosylated and it's important for attachment, and it gives antigenic variation. Question. Which of the following is a characteristic distinguishing feature of the respiratory syncytial virus that differentiates it from other members of paramyxoviruses? A. Respiratory syncytial virus lacks both hemagglutinin and neuraminidase proteins. That's true. It possesses single-stranded RNA. Both RSV and other paramyxoviruses do, and same with the -sense RNA, and same with the envelope. So the only difference between RSV and the other paramyxoviruses is the hemagglutinin and neuraminidase. Pathogenesis. RSV attaches via the G protein to the cells of the respiratory tract, causes necrosis and syncytia formation. Then you have cell-to-cell transfer of virus, forming mucus plugs and bronchoconstriction from local inflammation. Clinical findings include an incubation period of 4 to 6 days. Then you get the onset of fever, rhinitis, and pharyngitis. And if you're less than a year old, you're going to get bronchiolitis. That's characterized by a recurrent cough, tachypnea, respiratory distress, hypoxemia, and cyanosis. You do a chest x-ray and you find bilateral patchy infiltrates in the lungs. If you're a little bit younger, you'll get apnea, lethargy, irritability, and poor feeding. The lab diagnosis is based on viral culture. You can do a shell vial, but takes 48 hours. You can do a direct immunofluorescence. RT-PCR is the most common way to cinch down a diagnosis. And if you have 2 to 8 days, you can look for cytopathologic effects, and it'll form a syncytia. Treatment is often supportive. You use fluids, oxygen, humidification of the air, respiratory support with bronchodilators, but you can also try ribavirin or RSV immune globulin if you need to. Question. A 4-month-old female was brought to the emergency room with severe respiratory distress, wheezing, and with a fever. Her symptoms began with a cough and a runny nose. Her exam showed a temperature of 39 degrees centigrade, a pulse of 200, tachypnea, respiratory rate of 35 per minute, and she has significant intercostal retractions and nasal flaring. A chest X-ray revealed interstitial infiltrates and hyperexpansion. Which of the following is the most likely offending pathogen? So you're 4 months old, and you've got a pretty severe thing going on with your respiratory system. You're pretty darn sick. Respiratory syncytial virus is what you should think of with little kids. Mycoplasma pneumonia is the most common cause of atypical pneumonia in patients who are 6 months to 60 years old. But this isn't atypical pneumonia. This is something real with the respiratory system. Pneumococcus is an important cause of pneumonia, but this also doesn't sound like lobar bacterial pneumonia. We have bilateral interstitial infiltrates, suggesting a bronchiolitis. Adenovirus isn't a known cause of pneumonia, and so the most likely diagnosis is respiratory syncytial virus. Next question. The antiviral agents of choice recommended for treating RSV infections in infants is which of the following? Ribavirin is the answer for this. It's the only real indication for this medication. It's treating in RSV patients. Amantadine you use for influenza. Interferon alpha and gamma are our own body's responses to virus infections. Next question. Which of the following statements regarding ribavirin for the treatment of RSV is incorrect? A. It's been shown to decrease viral shedding. B. It can increase the patient's oxygenation. C. It must be delivered by aerosol. Or D. It can be administered orally and is associated with less toxicity by this route. Well, the thing you need to know about ribavirin is that it can be administered by aerosol. It does help oxygenation and it does decrease viral shedding. And so D is the incorrect, or D is the answer. Parainfluenza virus has 4 types. They're negative sense RNA, they're unsegmented, and they're single-stranded RNA. It has a spherical or pleomorphic shape, and it has a herringbone-like nucleocapsid core. It has glycoproteins like hemagglutinin and neuraminidase. These help with viral attachment, adhemadsorption, and hemagglutinin. It has a fusion protein like other paramyxoviruses, and it forms spikes, which helps fusion with the host. Transmission for parainfluenza is person to person with large droplets or aerosols of respiratory secretions. It can be viable on surfaces for up to 10 hours, and so it can live on fomites. Clinical findings include an incubation period of 2 to 6 days. Often patients are asymptomatic. When they do have symptoms, it's usually fever and a spectrum of respiratory infections. They can get rhinorrhea, pharyngitis, cough, or they can get a laryngotracheal bronchitis. They can get bronchiolitis or pneumonia. The most common thing for parainfluenza is to cause croup. Croup happens in patients who are 6 months to 3 years old. They get subglottic airway obstruction, inspiratory stridor, dyspnea, hoarseness, and a very distinctive seal bark cough. Once you hear it, you won't miss it. Lab diagnosis for parainfluenza depends on antigen detection or antibody detection. You can do immunoassays, viral culture, or the shell viral culture. You can look for serology for antibodies, hemagglutinin inhibition, and direct immunofluorescence. Also, we can do molecular testing by PCR. Question. A 2-year-old boy presents with a seal-like barking cough, inspiratory stridor, fever, sore throat, and headache. A viral etiology is suspected. The most likely diagnosis is... So this is croup, and the question is, what's the most common cause of croup? The other choices do not involve a seal-like barking cough. Epiglottitis is going to be more respiratory distress with a thumbprint sign. Measles is going to show up with a rash and coryza and Koplik spots. And bronchiolitis will have some inspiratory stridor and retractions, but you're not going to have a seal-like barking cough. Rhabdovirus is where rabies virus belongs. It's the causative agent for rabies. It's a negative sense, single-stranded RNA with an envelope that has a unique bullet shape. Transmission, as you know, is spread by bites from infected animals. In addition to dogs, you need to think about bats, raccoons, and coyotes. Pathogenesis for rabies virus includes the virus being inoculated into the tissue through a bite from an infected animal. Then it binds to the nicotinic acetylcholine receptors of the nerve or muscle cells at the site. It moves along the nerve axons into the central nervous system where it spreads to the brain. That's where you get encephalitis, coma, and death. The incubation period following the bite ranges from weeks to years. Clinical findings for rabies include a prodromal stage where you have pain or itching at the site of the wound. Then you have fever, headache, and vague GI problems. When you get the full-blown disease, you have hydrophobia, you're afraid of drinking water, you have salivation, you have seizures and hallucinations, paralysis, coma, and death. Lab diagnosis is based on serology. You can also do immunofluorescent antigen determination using a biopsy of skin, brain, or corneal specimens. Then you look for seizures and hallucinations. Treatment includes anti-rabies serum into the wound, vaccine, horse anti-rabies serum, and human rabies immune globulin. Question. Which of the following is true regarding rabies vaccines? A. It's used for post-exposure prophylaxis. That's true. B. It's a killed vaccine. That's also true. C. Has sufficient time to produce a protective immunity post-exposure. True. Or D. Safe to use in pregnant women. Also true. So all of the above is true of the rabies vaccine. Next question. A 45-year-old hunter was bitten by a coyote in a rabies-infested neighborhood. The animal was shot by a companion and brought to the public health authorities. Immunization against rabies should be initiated by which of the following? A. Hyperimmune serum only. B. Active immunization only. C. Hyperimmune serum and active immunization. That's true. So it's a lot like the tetanus vaccine. When you have the big risk of having the infection, you want to give the immune serum plus you want to vaccinate, not give them at the same site at the same time. Wrapping up Module 33, we covered a lot of ground. We started with swine flu. We talked about orthomyxoviruses. They have segmented genomes. They can have antigenic drift and antigenic shift. We talked about respiratory syncytial virus. We talked about measles and mumps. We talked about rabies. Each of these viruses has a unique strategy. They have clinical presentations which is most likely going to be given to you in the question stem. If you are familiar with the different families, the diseases they cause, and a few of those little pearls or little clinical features, you'll do well on step 1. You'll also do well when you encounter these diseases in real life. Next up, we're going to go to Module 34 where we talk about the positive sense RNA envelope viruses.